This is an extended version of the presentation that I gave to the Academy of General Dentistry on Friday, July 29, 2022 in Orlando. The title is Obstructive Sleep Apnea and Temporomandibular Disorders. Are they the same? What's the dentist's role? This is a very interesting topic for me because I believe that they are the same, that Airway rules supreme, and that TMD is a reflection very often of long-term chronic airway problems, particularly in children that develop to adults, which is a different view. A lot of people think TMD is, well, you got TMD. Well, I believe just like diabetes, there are like 5 stages of diabetes over 20, 30 years. Same thing with TMD. It develops and they are related. And this lecture will kind of look at the evidence. So I have no commercial disclosures. I don't accept money from any companies to promote their products. However, I am the founder and chief executive officer of the Atlanta TMD Institute, and the institute was founded by me 2018 to promote information, but to promote education, knowledge, and care of patients in the area of TMD. And of course, we're located in Atlanta. I'm going to start out with some obstructive sleep apnea definitions so that we're all on the same page and everybody understands what we're talking about. And these relate to polysomnography scoring. Poly means many, somno means sleep, and then graphy means writing. So sleep writing and scoring means to give a score, how well something is done, how bad something is done. First of all, the most serious thing is that apnea. A means nothing. Pneumonia, pneumos means lungs. Apnea means no lungs, no breathing. And apnea is a period of 10 seconds or longer without breathing. It has to be 10 seconds where the patient is struggling and not breathing, and they can't breathe. They're suffocating. A hypopnea is a period of less than 10 seconds without breathing. So they're having breathing problems, they're struggling, but it doesn't go as long as 10 seconds. They're both significant. Apneas are more significant, but when we grade them and we count them up while someone's sleeping, we put them together to form a index. So who has sleep apnea? Who has sleep apnea? So if we're doing a polysomnography, person goes into the hospital or goes into some center, they hook them up to a lot of stuff, and they sleep for an evening. Then there's a technician there watching and a recorder recording, and at the end of the morning, they add everything up and look at the results. So in adults, obstructive sleep apnea is defined as having an average of 5 or more apneas and or hypopneas. You add them all together in a 1-hour period of sleep, average, so that they average them, which is interesting because you can have a lot of apneas at the end of your sleep period and very few in the beginning, but they're simply added up. So the AHI, apnea hypopnea index, averages it over the whole sleeping period of like 7 or 8 hours. 5 is the lowest. There are different categories, but if it's 5 or more, you have by definition obstructive sleep apnea. So who are the big boys in the area of sleep? The group that makes all the definitions and says what's supposed to be. It's the American Academy of Sleep Medicine. And this is a group of physicians, MDs, who are dedicated to the area of medicine called sleep medicine. And it is one of the newest parts of medicine. And TMD is kind of like that too. It's been around for a long time, but it's just becoming understood, and the area of orofacial pain has become a specialty in 2020. So again, the American Academy of Sleep Medicine, these are the guys that tell us what's going on, right? They're the ones that govern this particular disease. So the American Academy of Sleep Medicine divides obstructive sleep apnea into 3 different categories based on the average number of apneas and hypopneas per hour in adults. And we're talking about the severity of that particular person's sleep apnea. So the first is they call mild. That's in the green. Mild apnea has an AHI of between 5 and 15 incidences per hour. In other words, they add up the number of apneas, the number of hypopneas, right? And then divide by 7 hours or 8 hours. And they came out to 5 to 15. They're mild. Moderate. Moderate is same thing, but 15 to 30 apnea, hypopneas. And then severe, which is severe and very serious, is 30 or greater. So this is what they have said. This is how they categorize the severity of apnea. Either it's mild, moderate, or severe. And that determines how you're going to treat it, how you should treat it. So physicians and dentists and medical professionals have come up with this term, standard of care. Standard of care is that which a reasonable practitioner would do in a situation for a patient. So, you know, this person has mild obstructive sleep apnea. Everybody would agree they should do this thing. All right. So the standard of care for treating severe sleep apnea is continuous positive pressure, or CPAP. Everybody knows what CPAP is. We have friends that have CPAP. It's very common now. And this gentleman is wearing a CPAP, and it is not the sexiest thing in the world, but it may save his life. But CPAP, severe sleep apnea requires the CPAP, no question. What is really, really interesting is that the American Academy of Sleep Medicine, who are physicians, MDs, recommends that dentists treat mild and moderate obstructive sleep apnea. I want to repeat that. I think it's really important, really kind of crazy, huh? The American Academy of Sleep Medicine recommends dental sleep appliances for mild and moderate obstructive sleep apnea. And dentists should be doing this. Unfortunately, again, because it's new, it's not something that all dentists do. And they're not all comfortable with it. I've taken a course, a 3-session course of Tufts and sleep, and of course read everything I could and learned, because for me it was new. We didn't have obstructive sleep apnea when I graduated from dental school in 1982. So also, get this, for patients who are CPAP intolerant. You saw that stuff that they got to wear all over their face, and they have to sleep with it, and they may have a bed partner, or they're single. It's just something that people don't like doing, and it's a high percentage. And in a minute, we'll go over that. So what does this mean? If a person can't wear their CPAP, they need an oral appliance. And I've given you on the bottom there a couple of different types of oral appliances. All of them advance the lower jaw forward. All of them do. You got the EMA, which has a rubber insert, which can be replaced on the far left. The dorsal type, the dorsal meaning fins. If you look at that, there's 2 vertical fins in the front, right? You got a hinge type, which is a Herbst appliance. We used Herbst appliances with kids. Oasis, and the TAP 3, which probably these guys are the most common sleep appliances. And patients put them in when they go to bed and sleep with them and take them out at the end of the day. They're portable. You can travel with them, versus a CPAP, which is a big machine. You got to carry that thing around if you're traveling. It makes it difficult. But again, these are the recommendations of the AASSM. So CPAP is very difficult to wear. People don't like it. It's obtrusive. It gets all over you. You're putting something all over your face, and people don't like people to touch their face unless it's a kiss, right? So the results differ based on what the studies are about how many people will wear their CPAP, but it ranges from 40 to 70% who receive CPAP do not wear it. 70% on the high studies. 7 out of 10 people that get a CPAP won't wear it. So wait a minute, they're going to die, aren't they? I mean, they've got obstructive sleep apnea. It's going to possibly they're going to have a heart attack. And by the way, these people die of heart attacks. And so when the death certificate says heart attack, it doesn't say obstructive sleep apnea, which gets really confusing, really, and for a lot of physicians. But here you go, 40 to 70% of patients who receive CPAP are not able to tolerate the CPAP during sleeping. This means, guess what? That most obstructive sleep apnea patients, by default, are being dental patients, right? Because mild gets oral appliance, moderate gets oral appliance, and 40 to 70% of the CPAP users gets oral appliance. Because if they can't use the CPAP, they have to use the oral appliance. So again, this is kind of an interesting thing because AASM says better to wear an oral appliance than not to do anything. So I don't believe that most dentists understand this. Based upon what we just discussed, this means that dentists, not physicians, are really the primary healthcare providers for most obstructive sleep apnea patients. Isn't that crazy? And the politics are crazy in this particular area between physicians and dentists are really the primary providers, but yet they don't get referrals from physicians very often. And it's a big issue, but we'll discuss that. And I think it first needs to be that you understand that you are the primary provider. So the medical literature often refers to dental sleep appliances as MADS, M-A-D-S, and it stands for Mandibular Advancement Devices. We have a section of human head and neck here. We're going to look at that. And if you look closely, you've got the tongue, you've got the soft palate hanging down, you've got the tonsils, the palatine tonsils. You've got the lingual tonsils, and then you've got an airway going down. If you look forward, and that airway, it needs to be protected, and that airway needs to be open. And by advancing the mandible, you're pulling all of those structures forward. So this is a critical concept, something you really must understand. Please, it has to do with the treatment of sleep apnea. So when taking a bite registration, in other words, determining how the upper jaw and the lower jaw are going to fit together in your appliance, when taking a bite registration for a mandibular advancement device, the clinician dentist almost always advances the mandible forward several millimeters forward to their customary bite. Got it? And this is called the George gauge. I don't use it because it's a straight movement. I think it shouldn't be just straightforward. It should be a 3D bite position that the MAD puts the lower jaw into. But the George gauge is very popular, and what does it do? You literally use it to be sure you've advanced it, 4, 5, 6 millimeters. That's what the George gauge makes sure that you do. So I've circled around the mandible, particularly the anterior mandible, and in the bottom of the mandible is a muscle you can see. It's called the it's geniohyoid. And the geniohyoid muscle goes to the hyoid bone in the throat. Hyoid bone is like the center of all activity. It holds all the muscles in the breathing area. And if you pull that hyoid forward, it opens up the entire airway, opens up the throat so people can breathe. And that's what happens when people have obstructive sleep apnea. This whole area, this lower area here below the circle, that area collapses. So here's the mandible removed from the human. I think this comes from Cicher and DeBrule. And you're looking at from the back, like you're looking out of the mouth. And there's the geniohyoid muscle from the back of the mandible all the way down to the hyoid bone. You also have the mylohyoid, which is a broader. Mylohyoid represents the bottom of the mouth. So the two geniohyoid muscles attach to the inferior geniotubercles on the inside of the mandible. So there's 4 tubercles, which are like little bumps, little breast bumps, right? And there's 4 of them, 2 on the top, 2 on the bottom. 2 on the bottom are inferior, 2 on the top are superior. Genio means the anterior part of the mandible, right? Tubercles, which means bumps. So this particular muscle, the geniohyoid, attaches to the inferior geniotubercles right in the front of the mandible. The mylohyoid also attaches to the mylohyoid ridge on the inferior surface of the mandible, and then it goes down backward and attaches to the hyoid. So both of these muscles pull the hyoid up when you move the mandible forward. Likewise, in TMD often, the mandible goes backward and this hyoid bone drops into the throat, and it creates a problem. So if you start thinking of the mandible as a structure that moves right, left, forward, back, you're going to start thinking, oh my God, I'm influencing a lot of other things besides just teeth. And dentists think, oh my God, if I move forward, I'm out of my bite. Oh, I'm out of my bite. I'm out of my bite because you're a tooth doctor. You need to be thinking about a human being doctor and what are all the structures that are being influenced by moving that mandible. As the mandible advances, it pulls the geniohyoid and the mylohyoid muscles forward, thereby opening the pharynx. The hyoid is the insertion of both the geniohyoid and the mylohyoid muscles, so the hyoid bone is pulled forward when the mandible is positioned forward. The whole concept is when you move the mandible, mandibular advancement device, the MAD, forward, you're pulling that hyoid bone forward, but you're also moving the entire mandible forward. Both of the condyles are moving forward, and they're coming out forward. They're coming forward into their mandibular fosses or their sockets, where they're supposed to be. So what does this MAD do? You know, we know that it's pulling the geniohyoid, the mylohyoid, and the hyoid forward with all the muscles in the throat forward. And basically, it's opening up the bag. It's like a big Kroger bag. And I have a bag here to indicate that. And what area is being pulled forward? The area on the bottom where I've circled in the throat, all right, or in the neck. Very important. The neck structures are what are being opened up. It's very interesting. And you can look at people and they have fatty necks. You can see how thick and fat their necks tend to be because there's so much metabolic syndrome in the world right now, so much diabetes. And this complicates the sleep apnea, complicates sleep. And essentially, anything that makes that neck collapse is going to cause sleep problems. But the MAD opens up the throat like a bag. So this is the second critical concept that you must understand, because we're talking about anatomical, physiological problems that people have, and what is happening when we're treating patients, right? So if you have to advance the mandible position forward to facilitate breathing, right? So forward's good. We know that. We can sleep test them with a MAD in, and they're better. So if you have to advance the mandible position forward to facilitate breathing, guess what? Then this forward position by definition and by clinical practice, get this, is the natural, most physiological position of the mandible. Lord almighty. Wait a minute, but this means the teeth aren't together. Oh my God, dentists just can't handle this. They start shaking uncontrollably and they can't handle it. But the truth of the matter is that the jaws are getting smaller, people getting heavier, fat's going everywhere, things are being blocked off, and natural position of the mandible is forward, not backward. Unfortunately, the mandible grew inappropriately, incorrectly, and it's universal in the United States and the world right now. So the next question that's going to be brought up is what causes the modern human mandible to be retruded and to block off the airway, especially at sleep? We see a very nice profile on the left. Everybody looks at that and says, that looks really, really good, that left guy. Same guy drawn with his jaw back. His mouth is open, his lip curls upward, he doesn't have a very good chin. The angle of the chin of the lower jaw and the neck is rounded, not sharp. This is a person who looks sick, but yet this is very common. As many as 70% or 50 to 70% of people in the U.S. have this right-sided profile, right? And this is due to growth and development problems. What is very, very interesting is if you look at the skulls, upper and lower jaws of our ancient ancestors, they didn't have sissy jaws. They didn't have underdeveloped jaws. They have plenty of room for their wisdom teeth. Now everybody gets their wisdom tooth out. Why did God put wisdom teeth there? Oh, so that they could have oral surgeons. I don't think so. At some point, something went wrong, and our ancient ancestors didn't have this problem. Our ancient human skulls have adequate space for all 32 teeth within a broad maxillary and mandibular arch form. So the upper arch, the lower arch, huge, and it's very common. They're also very flat because they ate things with dirt in them, or they ate bread that has stone ground in it, and little pieces of stone. But look at this arch. It's huge, right? This arch is huge. And this is what you see and typically see in ancient ancestors. I read this book, Nutrition and Physical Degeneration, early after I graduated from dental school. And I did it. I thought it was very interesting. I did. But as I get older, I'm understanding the consequences and the things that Dr. Price has picked up. And basically what Dr. Price found was when you have people on the left who are eating their natural diet, unprocessed foods that just brought from the ground, raw, and a lot of very minimally cooked foods, you get these beautiful broad arches with plenty of room and teeth everywhere. The girl on the lower left, ooh, look at how beautiful the teeth are. But then these same people in one generation, all of a sudden, we start bringing in processed foods, civilized foods, not their natural foods, and all of a sudden, on the right side, within a generation, you see crowding, dental crowding, cavities, all sorts of problems. But it is within one generation, which means we go in, we want to civilize these people. We go in and we give them food. We sell them food, and the food sucks. It's soft and it's not natural, so they don't chew on it very well, and it's also very often devoid of a lot of real nutrition, and so you just don't see, you can see it in the faces that these people are sick, the people that are eating the civilized foods. And Weston Price showed this clearly, and it's just a great book to read. I would highly suggest that you read it. You can also get an audio on it right now. So if you don't want to read, listen to the audio. But he was right on the money when he said it is our diet that's causing all this. And he pointed to the nutritional problems because he was looking really at cavities. However, I think it's also the mechanical chewing that you have to chew, chew, chew to develop out. If you use it, if you don't use it, you lose it. So if you're eating mushy foods all the time, your jaw's just not going to grow. How can it? You're not weightlifting. You can't be muscle bound if you don't lift weights. So this is a malocclusion. Mal means bad. Occlusion means we use it the bite of the teeth. If you looked at the previous picture, Weston Price's picture, the far right bottom corner is almost the same as this. Uh, why does the jaw not grow? Because of growth and development disturbances. This is the jaw didn't grow. Right? It was disturbed. Something didn't happen that should have happened. This makes sense. So what is the incidence of malocclusion? And in this particular study, there's only one study, it's from Italy, was 56%, which means more than half of the people in Italy have malocclusions, which makes it more common than normal bite, right? And this is just in Italy. Another study in growth and development disturbances from India. The incidence of malocclusion, bad bites, is approximately 76%. Oh my Lord. And I believe that that's pretty much what the US figure is. So the diet that everyone eats is causing everyone to have malocclusion. I mean, that's the thing that I'm saying. And there are actual studies that have been done with a gentleman at Harvard who put a bunch of animals with sloppy food and natural food, and the natural food caused development of the jaw. Lieberman is his name. So Daniel Lieberman, who is an anthropologist at Harvard, did a study the effects of food processing on masticatory strain and craniofacial growth in a retrognathic face. And this is what we're talking about. Retro means undeveloped, backward. Gnathic means jaw, poor jaw, small jaw face. And he basically fed these hyraxes. These are small animals in the lab. Food that was very soft, and food, and then a separate part, hard natural foods. And the two of these, they're the ones with the soft foods had very poor facial development. The jaw didn't develop. All the craniofacial bones did not grow. And this is so interesting. He's written some other really interesting books that I would highly suggest that you take a moment to read. I think Dr. Lieberman also wrote The Evolution of the Human Head, which is an extremely, extremely interesting book. Remember, we're working in the craniofacial area of the skull, and it behooves us to know what's going on and how the structures of the skull work, how they evolved. He also wrote another text, The Story of the Human Body, Evolution, Health, and Disease. Again, how did our structures get this way? Why are our teeth formed the way they are? Why is our face the way it is? And so these are really good things to think about. And I think they become more and more interesting to clinicians after we've been treated numerous patients. Here's a study which is in the orthodontic literature by a dentist called Harvold. And what he did is he's thinking, well, what disturbs growth and development in the facial area? How about breathing? So he put Teflon plugs in monkey faces and forced them to breathe through their mouths. And this paper is just amazing. And it showed the craniofacial developmental problems all over the place. So mouth breathing is terrible. Mouth breathing also is extremely common in OSA patients. Just think about this. And very common, I think, in TMD patients too. But mouth breathing is terrible. It has, really, the mouth is not designed to be a breathing port. So what were the results of his experiments? Well, basically, people with mouth breathing had malocclusions. Monkeys with mouth breathing had malocclusions. They couldn't breathe correctly, and they came up with different strategies to get oxygen. And unfortunately, mouth breathing is just not natural and causes the face not to be natural. And there are just so many signs inside human faces that show you disease, and the external face reflects the internal problems. And again, this is what Dr. Harvold proved, that craniofacial form is dependent on nasal respiration. So a lot of us were issued skulls when we first became dental students, probably the first week, when we had to do skull osseous anatomy, osteology, at the beginning of our human dissection. And we began believing that this skull doesn't change. It's like a rock, right? A fixed structure. And it is not. Bone adapts. It's very important. And bone is also plastic. If you do enough surgery, you can see it moves and it shapes. It has some plasticity. Wolff's law of bone tells us how bone behaves. Bone in a healthy person or animal will adapt to the loads under which it's placed. If loading on a particular bone increases, the bone will remodel itself over time to become stronger to resist that sort of loading. The internal architecture of the trabeculi undergoes adaptive changes, followed by secondary changes to the external cortical portion of the bone, perhaps becoming thicker as a result. So bone is dynamic. Bone changes. The external part of the bone, the morphology, the remodeling, and the internal portion of the bone. Bone adapts to its situation. This gentleman has perhaps influenced me more than any other dentist, in that he developed the functional matrix theory. And basically, this theory states, and this is a dentist at Columbia University, the origin, development, and maintenance of all skeletal units are secondary, compensatory, and mechanically obligatory responses to temporally and operationally prior demands of related functional matrices. What does that mean? Well, the muscles that compress the dental arches make the dental arches smaller. The muscles that expand the dental arches make the dental arches larger. Teeth float in bone, right? Believe it or not, bone is dynamic mostly everywhere. And that basically what Moss is saying is that function dictates the form. You have a basic genetic blueprint, but that genetic blueprint is modified by the function. And we saw that with Lieberman's Hyrax experiments. And you see it in a lot of different ways, in a lot of different situations. But again, function dictates form. So there are numerous examples demonstrating that bone remodels based on the pressure placed upon it, its situation, its stresses and strains. And we see that Inca nobility bound their children's heads and caused their brains to become cone heads. Perhaps this is where they've got the Saturday Night Live cone heads. If you look at the right side, an African tribe that puts rings on and stretches the neck. This all came from pressure applied to the neck, pressure applied to the skull. Again, in this child with hydrocephaly, the bone kept on growing, because of the pressures within inside the brain case. And that's very interesting because the growth of the brain dictates the growth of the skull. Right? The brain pushes out, makes the skull grow. Again, it used to be a Chinese custom to bind feet on females. And if you look at this foot to the left, this is a bound foot, and all the bones collapsed inward compared to the normal on the right. So bone responds to its environment. So now that we've kind of looked at that bone response to its environment, what influences the shape of the maxilla, the development of the maxilla? What influences the shape of the dental arch, upper dental arch, lower dental arch? What influences the growth of the mandible, right? What is it? What is the elephant in the room that is the pill that causes everything to go bad? So the elephant in the room is primarily the tongue. The tongue development. The tongue is essential for survival. The tongue manipulates food while we're masticating. The tongue manipulates food for swallowing. The tongue creates speech, informs speech. It's extremely important. But it is the primary muscular component, the biggest muscle inside the orofacial area, right in the center portion of the orofacial area is the tongue. So we should become knowledgeable about what the tongue does, right? And then we should also know that when the tongue dysfunctions, it causes speech problems, masticatory problems, and swallowing problems, but it also developmental problems. So tongues can have a lot of different forms. They respond to their situation also. And these are two people with real tongues. These tongues are not, these pictures are not doctored, and they come from Ripley's, believe it or not. But these are real tongues. So what does the tongue do? It provides all these red arrows, right? It develops the arches laterally, got it, from when during swallowing, right? It drops the palate as if you think of the palate as a sheet of paper that's in a dome, as you expand the edges of the paper, the palate drops. So lateral tongue pressure during swallowing and during mastication expands and advances the dental arches, expands the palate, and drops the height of the palatal vault. The tongue basically serves as a template for the maxillary arch size, form, and position. The tongue must be able to fit up into the maxilla in order for you to be able to swallow, right? And swallowing is really important. And the tongue needs to be able to fit neatly up into the palate to create a negative suction so that when you breathe, the tongue stays out of the throat while you're breathing. Another important evidence showing the importance of the tongue is what happens when you don't have a tongue. We have aglossia, and these are pictures of two different patients who had aglossia, and you notice there's just zero development of the maxillary or mandibular arches. It just doesn't form. The tongue function is absolutely necessary. It's so interesting that form and function integrate intimately. And so we ask, what is the function? What are the functional things that occur in the masticatory area, the oral area, the stomatognathic area that we work in? So the maxilla grows anteriorly forward, laterally outward, in response to the outward and forward pressures applied to the palatal surface of the maxillary bone, primarily by the tongue. And in here I have the phases of the swallow. So it's the oral preparatory, and we're focused on that. We're thinking about the mechanical breaking up of food into a soft bolus. That's what we do. We think of teeth, functioning well, integrating well, so that they can do their job in their particular part of the swallow. But they're only one participant in this whole panoply. And so you have an oral preparatory phase. Then we have to swallow that bolus. And that means that we have to put the tongue on the palate, squeeze backward and outward, and get that thing down into the throat. Then we have the pharyngeal phase. This is when you pretty much go at or below the hyoid bone. And that's regulated by a different set of muscles. And finally, the esophageal phase. And the esophageal phase is like totally controlled by the autonomic nervous system. It's all automatic, but the rest we can modify. And we look at the palate, the height of the palate, right? The palatal fossa. And this is the development, our teeth and arch develop out and from a correct swallow. And this height is directly related to otitis media, inflammation of the ear, inside of the ear, the middle ear, through the eustachian tube. So you really do need good anatomy, broad arches to function well and be healthy. And this is just, well, what happens when the palate expands laterally and anteriorly as the tongue functions correctly? Well, the palatal vault descends, the nasal septum descends because as the palatal vault goes down, it pulls the nasal septum down, makes more room in the nose, and it avoids the deviated septum. The nasal fossa enlarges not only vertically, but laterally. There's more room for the sinuses also. The maxillary sinuses enlarge. The airway enlarges. There's papers that show that like a 2 millimeter development of the palatal arch with rapid palatal expansion, which by the way I don't believe in. It should be slow and natural. You get like a 20-30% increase in airway resistance, a decrease in airway resistance, and also the mid-phase height increases. So I just did this this diagram where you take a piece of paper and you arch it, and you take the molar teeth, anchor it, and you take the piece of paper and stretch it to the right and the left, and the palate drops, the nasal septum drops, and the palate becomes flatter. So a flat, broad palate is normal. So I basically did some brief sketching here. You can consider the nose on the left side a triangle. It has a vertical height. As the palate descends, the nose lengthens vertically. The base of the nose of the triangle, where the maxillary sinus exists, when the molars go laterally, that develops out the nose. And on the right side, you'll also see 1 and 2. 1 is the nasal septum without the palatal descending, and as the nasal septum grows in a short area, you start getting buckling, which is a deviated septum, and as the palate expands, that septum goes down straight. So, and this is a big operation that you see often with ENTs. Now, I want to stop for just a brief moment and say, yeah, the tongue is probably the most important muscular structure in the development of the somatognathic system, but tongue dysfunction is not the only thing. So tongue dysfunction plays an important role in the origins of OSA, TMD, and malocclusions, but I've got to say there are a number of other factors involved also. And it's just not simple. There's a lot of stuff going on. You got the masseters coming in, you got the lateral pterygoid pulling forward, you've got on the condyle, you've got, the inframandibular muscles, the digastric, right, the geniohyoid. All of these muscles are playing a part in forming and through their function, the masticatory stomatognathous area. So as dentists, we know teeth and we love teeth. We look over here and we see these teeth integrating beautifully, and it's just so satisfying. You know, this is what our objective is when we're mechanically returning the form and function of teeth. This is what we do. And the cusp and fossa of the mandibular teeth must fit into the maxillary teeth, and that's how eruption is guided. But there's more to it, that we have to be thinking beyond just teeth. We make the assumption that if a patient doesn't complain and say that there's pain, that we have a normal orientation of the mandibular condyle bilaterally. We just don't think of that, do we? I mean, it's just not something that we are integrated into thinking. Where person comes in, we want to do a root canal. Person comes in, we want to do a crown. Person comes in, we want to do a composite. Person comes in, we want to do a whitening. We're thinking teeth, teeth, teeth. But the health of the mandibular condyle is extremely important, and it is there. So a key concept to remember is that teeth are attached to the alveolar process, which is attached to the base alveolar bay, the base of the alveolus, which is attached to the entire mandible, right? And everything is one piece. It's like a whole bunch of people in a truck. As the truck moves, the people move with the truck. So the mandible is one bone with both mandibular condyles part of one bone. When the mandible is advanced forward in the construction bite for a MAD, this mandibular advancement moves both mandibular condyles forward and often down, almost always down, because of the slope of the articular eminence in their respective mandibular fossa. So just remember, when you're moving teeth, you're moving bone, always. So here's the kicker. All right, we see these teeth integrating nicely, and we're very happy in our lives. We don't think about anything else, right? We're insulated. But what if the maxilla is retruded? You know, what if the maxilla never developed out to its full potential forward and laterally, right? You have to remember the occlusion dictates where that lower jaw has to sit, because if it doesn't integrate, it doesn't function. So if the maxilla is retruded, for the mandibular teeth to fit into the cusp and fossa of the maxillary teeth, the mandible must retrude. It has to posture itself backward into the existing retruded maxillary position. So the teeth fit nicely, and we're looking at these teeth, and we love these teeth, 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 teeth. And guess what? This particular patient, when they bite into their occlusion, the condyle is slightly displaced posteriorly, crushing the retrodiscal tissues and just creating all kind of havoc back there. And what's really interesting is a lot of the early pain is nociception without pain. Nociception without pain. How often have you asked a person if they are having any kind of problems? They say no, and then you palpate the lateral poles of the temporomandibular joint, and they jump out of the chair. There's plenty going on there. It's just that they don't know about it, and guess what? You don't know about it. So this is an extremely sad situation. It is real, and several people lost their lives here, following too closely in front of a semi with another semi behind you. You can't do this. When after I was married, we were coming home from Savannah, Georgia, and we had a truck playing with us behind us really, really closely. And I tried to get out, and there was another truck coming bombing up on the other lane too. And I had just a sissy car and slammed on the gas, and we hardly moved, and we did get out of the way in time. But this is what's happening to the retrodiscal tissues. They're getting crushed. Don't fool yourself. They're getting crushed. So when you palpate that temporomandibular joint and it hurts, most likely this is what's happening. So several of the academies have adopted the Gelb 4-7 position as the ideal anatomical. Some people say, well, it doesn't have to be slightly forward like that. It could be centered. But every single one agrees it can't go backward past the apex of that mandibular fossa. You can't do that. There's tissues back there that are going to hurt. And God never meant for us to go back there to crush anything. So occluding in a retruded mandibular position distalizes or posteriorizes the mandibular condyles and compresses the retrodiscal tissues. I think everybody will agree to that, no matter what philosophy you come from. This causes nociception with a central nervous response. You know, the body doesn't want this. It's going to react by muscularly pulling things forward out. And this is why I don't believe in Botox, because most of the time those hurtful muscles are trying to accomplish a task and they can't do. And then instead of assisting them, you're knocking them out. You know, so again, we're starting to get an appreciation. We look over at these teeth, they look fantastic. We're dental people, we love teeth, we love teeth. If the maxilla is retruded for the mandibular teeth to fit into the custom and fossa of the maxillary teeth, the mandible must retrude into the existing retruded maxillary position. I've just repeated this, but guess what? Now we get even worse. So here we see something even worse. If you look at the condyle now, it's almost touching the anterior wall of the tympanic chamber. And we're focused on the disc. You see the disc going forward? So we're like, oh, we hear a click. We're thinking about the disc. Disc, click, click, click. I call it clickology. And really in the 80s, that's when we were focused on clickology. And everything was the diagnostic based on what sound there was. But wait a minute, it really should be, what is the anatomical problem? What is the anatomical distortion? And how should we treat that? Not so much click. But here we have an advanced displacement with a nice occlusion. So the next thing is, well, geez Louise, how do we treat a advanced displacement into the retrodiscal tissues in the condyle, right? So as both mandibular condyles move down and forward, they assume a more physiologic position within each mandibular fossa. This position allows the intermediate zone of the articular disc to sit on top of each mandibular condyle as it's designed to do. So we're going to advance that mandible. So there we go. We've advanced it to normal. Isn't that wonderful? So now notice the disc has been recaptured, and that's a whole issue right there we don't want to get into. But the disc is better. The condyle centered. It's more like the Gelb 4-7 position. Life is good, but what did we do to the occlusion? So Lord Almighty, we had to advance the mandible forward to get off of the retrodiscal tissues, right? And we get this situation where we're down and forward. We might have some anterior contact or not, depending on how deep the overbite is. But look, we've messed up the occlusion. Oh, this is so a dentist will react, right? It's sort of like someone questioning your religion, and they'll just get upset. But this is what we do with mat appliances. This is what we do with mat appliances. And guess what? This is what we really have to do when we have severe advanced condylar displacement. I just can't, I don't care what people say. I know that crushing is toxic. And I know that I've got to move that condyle forward. It's just completely sensible. So what happens to the tongue and airway when the mandible is retrusive? It's backward. While the tongue is abnormally positioned backward in the oropharynx, and this abnormal tongue positioning interferes with the ability to breathe, right? And remember, it's not only backward, it's upward, which causes the uvula to touch the back of the tongue and you see snoring. As you bring the tongue forward, right, and downward, you eliminate snoring. Isn't that, wait a minute, I moved the mandible forward and down, and I eliminated snoring. Must be good. Sorry, I'm sorry. You need to look at the results of what you're looking at. It also creates a more natural posture of the pharyngeal muscles and the angulations of the pharyngeal muscles. Everything is more anatomically correct. So I'm just going to make a statement that, what is obstructing the airway in OSA? Right? This is, we'll argue. We'll say, well, it's the pharyngeal collapse, has nothing to do with the mandible. I don't believe that. What is damaging the temporomandibular joint in TMD? It's a retruded mandible, right? You're choking off the airway, number one, physically. And number two, when you choke off the airway, you also create muscles like certain lengths, right? And when you change the length and angulations of these muscles and you don't use them correctly, they can't function correctly. So you're going to start seeing pharyngeal muscle dysfunction when the mandible's not in the right place and people aren't chewing correctly. But it's a retruded mandible. The temporomandibular disorders and obstructive sleep apnea often have common etiological factors and are commonly found as comorbid conditions. Matter of fact, OSA or symptoms of OSA usually precede TMD signs and symptoms. So I believe that dentists should be leaders in the area of OSA and TMD, that we haven't really we haven't treated the TMD patients that are right there in our practices because we haven't been looking, right? We haven't been asking questions. It's not part of our training. With the new orofacial specialty in 2020, we might start having lectures to general dentists and change protocols so that the kids that are graduating now will have exposure to this. But what's your responsibility? And it is a big, giant responsibility. I think the first thing is to eliminate dental myopia. And dental myopia means teeth, 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 teeth. I would like to do a root canal on the tooth. I would like to do a composite on the tooth. I'd like to extract that tooth and put an implant in. I'd like to put a bridge over those teeth. I'd like teeth, 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 teeth. We need to be thinking not just teeth and gums, but also swallow and sleep and breathing, because that is part of the function of the area that we work in, and we can't ignore it. So we know that the oral area, the stomatognathous system, is extremely important. It was the first neuromuscular structure in the evolution of the human body. It was, and it is it's the portal of entry for most infections. We have to be cognizant of this. The first dental college in the world was Baltimore College of Dental Surgery, and it was established by, guess what, two MD-DDSs. We're starting to see MD-DDSs now, but way back then it was physicians that loved doing dentistry and converted their practice to dentistry. They thought holistically. They thought that, okay, these teeth are part of an integrated system, a medical system, and we need to think of that also. We don't think of that right now. We're just tooth doctors. We're mechanical people. We think more like engineers rather than software programmers. So I think it's extremely important that we take a different view, we advance our view, and we develop it to the proper place where it needs to be. We need to take over or at least supervise TMD completely, head, neck, facial pain, and we need to look at sleep because we are the primary providers of sleep therapy. But I think we're totally, completely delinquent. And we've let our medical colleagues take this area over completely and not get involved dramatically. And we just sat back and let them do all of this, when in fact it should be team-led, patient-oriented, and the optimum care of the patient should be primary, not the specialty that they go to first. It's a statement made by Dr. Thomas Bond, an MD, who taught at the Baltimore College of Dental Surgery. The Baltimore College of Dental Surgery was organized with the design of teaching dentistry as a regular branch of medicine, in which relation only it can be regarded as a scientific pursuit, and the practice of it esteemed as a profession. So again, we have our original origins, and somehow we broke away from these origins. And we have to remember that the mouth is part of the human body, and it can't be separated. I think as years progress and research occurs, we're finding our area is so extremely important to the health of the human being, and that we need to be considering much more than just simply teeth as something that we treat at what we treat. This is a book that I purchased soon after leaving dental school, and it was written by Alfred Fonder. It's entitled The Dental Physician. And basically, Dr. Fonder outlines how important dentistry is to the overall health of the human being. And this book just illustrates this in so many different ways. And I'm going back now and rereading it and seeing things that I didn't see way back when, and how far advanced Dr. Fonder was. Dr. Fonder also wrote a book, popular book, The Dental Distress Syndrome. And this is amazing. It's basically what kind of symptoms and signs throughout the whole body do you see with people that have TMD? Oh my God. This particular book kind of blew me away and included postural problems. He was so far ahead of his time that's unbelievable. And that, I read things like this when I was a kid, a baby dentist, and kind of understood it, seemingly understood it. But now as I get older, towards my twilight years in dentistry, I'm seeing the incredible array of problems that can occur from TMD. So what's your responsibility? I mean, what should you do? The American Dental Association has said that dentists are supposed to screen every single patient for TMD. Do you do it? I'm going to say most people don't. But what should you do? You should train your staff to recognize the signs and symptoms of temporomandibular disorders, especially your hygienist, because there's just so many ways that the hygienist, people come in, they can't open very well while they're getting a cleaning, they possibly have TMD. When they get a cleaning, they tell the hygienist, I have chronic migraines. Most of the time that's going to be TMD. But train your staff to recognize the signs and symptoms. Train your staff to recognize the dental signs and symptoms of obstructive sleep apnea. Come on, scalloped tongue, flattened teeth, right? Morning headache and hot and cold sensitive teeth. There's flat teeth, just all kind of stuff that your staff can pick up. You should also know and integrate into your exams. Consider, asking patients a series of questions, or add these questions to your, intake medical form. Ask your patients important questions and listen to their answers. Do you get headaches on the side of your head? Do you wake up with a headache? Do you wake up tired in the morning? Do you constantly have a dry mouth? Do your jaw joints make noise when you're eating or speaking? Has anyone said that you snore? Do you have difficulty sleeping at night? Have you ever worn a CPAP for sleeping? Does your sleep partner say that you sometimes shake while you're sleeping? Does your patient have a big belly and a fat neck? I mean, I put parentheses, don't put that on the medical form, but you might add some of these questions to your intake form. And this can be the most difficult part, is to find a sleep doc that will work with you. Try to find an actual sleep specialist. That's what his specialty is. A lot of ENTs, pulmonologists, they kind of jump in, they take a weekend course, and they start doing sleep tests because it's $2,000 to $4,000 a hit, 4,000 for CPAP a hit. It's huge profits related to this, so there are medical professionals jumping in. In the state of Georgia, dentists are not allowed to do sleep studies, unlike many other states. And this is all a political turf problem in that I think we are totally competent to do this, but I cannot do that in my particular state. So I have to establish a professional relationship with a sleep physician or physicians. Go find out who's doing sleep in your community, bring them to dinner. Establish a professional relationship with a sleep physician in your patient's best interests. Then make appropriate referrals for sleep studies. And then as you develop that relationship, you'll start making sleep appliances, and you'll also recognize TMD patients because they're a huge, they're part of this population. And finally, I think you should learn everything you can about temporomandibular disorders. It's an incredible field. There are tremendous amounts of relationships, so many things that affect our patients' lives every single day. And if you ignore this, you're going to be less than optimal in terms of the care that you're providing to your patients. If you're a tooth doctor and not a human being doctor, there's going to be things that you're going to miss that you could help your patients with. Again, learn everything you can about temperamental disorders because you will often find yourself doing truly amazing things for your patients. So I really did dedicate, the end part of my life and a good bit of my professional life to treating TMD because the dramatic effects that improve my patient's health caused me to just be fulfilled completely. And so I have dedicated myself really to TMD patients. I'm writing an extensive several volumes entitled The Biological Basis of Temporomandibular Disorders. I do have probably the keystone work, which is over 10 years old in development, The Etiology of Temporomandibular Disorders. This is almost ready to publish. If you wish to be a reader, I will provide you with a copy of this for free, and you can read it and throw stones at me. And I'm really happy to do this. And basically, it gets into a lot of stuff about TMD. If you're interested, please email me at drpodolsky@Atlanta TMD Institute or visit www.atlantatmdinstitute.com or give me a call. I would love for you to get involved. I will send you a PDF of it. You should print it out, read it, write notes, and then guess what? I will, at no charge to you, conference with you related to this book because I want as much feedback as I can possibly get. Two of my most favorite people in history, well, I have several of them, but I equate Churchill, Winston Churchill, and Theodore Roosevelt had this pretty much the same temperament and viewpoints in life. And this particular statement that he made hits me extremely important because we so much have a fear of failure. So that as we go into areas like of dentistry that we're not as familiar with, we want to know everything before we start. And that's not necessary. You just need to be a participant, and that's how you learn. So he made this statement, and I'm going to conclude my lecture with it. It's not the critic who counts, not the man who points out how the strong man stumbles, or where the doer of deeds could have done them better. The credit belongs to the man who's actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, because there is no effort without error and shortcoming, but who does actually strive to do these deeds. Who knows great enthusiasms, the great devotions, who spends himself in a worthy cause, who is at the best, knows in the end the triumph of high achievement, and who at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who never know victory or defeat. So go out there, learn as much as you can about TMD and OSA, and treat these patients. It's extremely important. And you're in the vanguard of changing dentistry because there's so many people that need to be treated by you. There is an epidemic of OSA right now in children, and they need us, and you need to be there. Bring yourself up to this. And thank you.